Hello everybody, and welcome to this virtual symposium, which is a contribution to the ePCR virtual meeting substituting for EuroPCR itself in Paris, France. My name's Prendergast, an interventional cardiologist from London, UK, and our topic today is the management of aortic stenosis in the context of the COVID-19 pandemic. How we readdress our treatment options and pathways to serve the needs of patients in this very difficult global crisis. I want to tell you first of all about a patient. This is a patient who was referred to our heart team 3 days after lockdown in London at the back end of March. A 64-year-old man with severe symptomatic aortic stenosis who presented with several episodes of exertional syncope. He had good left ventricular function and normal coronary arteries, and other than significant obesity, had no other major comorbidities. His CT demonstrated dimensions suitable for a TAVI procedure via transfemoral approach, but his logistic Euroscore was low, indicating that surgery would be the normal conventional treatment. At this time, non-emergent cardiac surgery had been suspended in London, and the outlook for that situation was uncertain. And clearly there were major questions to be asked of the heart team as to how we should manage this patient. The reason for that is that we recognize that aortic stenosis is a time-critical progressive condition. And as this cartoon illustrates, progression of the aortic stenosis and damage to the left ventricle is inevitable progression with time. We also recognize that in aortic stenosis, there are several indicators of poor prognosis. Syncope as a symptom, congestive heart failure as a syndrome, and echocardiographic parameters of left ventricular impairment or valve stenotic severity. At the same time, we recognize that waiting for a procedure is associated with significant morbidity and mortality. And these data from surgical and transcatheter waiting lists compare very poorly with our current understanding of the mortality associated with COVID-19. We therefore need to develop strategies to categorize patients and offer urgent treatment in a timely fashion. Patients with a critical condition may be suitable for urgent balloon aortic valvuloplasty in certain scenarios. And in others, we may wish to proceed to an urgent TAVI procedure as an alternative to surgical aortic valve replacement. In other scenarios, elective or deferred surgery may be the most appropriate treatment strategy. And at the same time, we recognize that the distinction between a surgical patient and a TAVI patient is changing on a year-by-year basis as the result of the accumulating evidence to support the use of TAVI compared with surgery, and the lowering of both age and risk thresholds in many countries, as exemplified here by a recent position statement from the German cardiothoracic societies. So we hope to address these issues and patients such as the one I presented to you in this symposium, which has been supported by Edwards Lifesciences. We will first hear a presentation from my colleague from London, Dr. Neil Ruparelia, as to how we address the concerns and the needs of patients as they wait for a treatment for their aortic stenosis, or indeed wait to present to a healthcare physician with their symptoms of breathlessness, dizziness, or syncope. We will then hear from Francesco Saia with an Italian experience emerging from the COVID-19 pandemic, which affected Italy very significantly, and as how patient pathways need to be restructured in the COVID-19 era. And finally, we will hear from David Wood from Vancouver, Canada, as to how we can further simplify and refine our treatment pathways and our procedures themselves to ensure the best clinical outcomes and the shortest duration of hospital stay. So I hope you will enjoy the session. And now I would like to turn to Neil, who's going to open with the first talk of the seminar. Neil, thank you very much.
So thank you, Bernard, and thank you for the kind invitation to speak as part of this session. And so the COVID pandemic has really brought around a number of challenges with regards to the whole of medicine, specifically with regard to the management of the most vulnerable patients in society. And indeed, with regards to severe symptomatic aortic stenosis patients, this is exactly the population where public messaging has been really quite stringent with regards to protecting themselves due to the very poor outcomes associated with contracting COVID. Now, with regards to aortic stenosis patients, these are the most vulnerable patients in society, and this environment has its own challenges. Firstly, it's been very challenging indeed to identify these patients due to this. And in fact, many patients don't present or present late or indeed cannot get access to healthcare, which has been a major challenge, especially as healthcare systems have conflicting and sometimes very difficult priorities, especially in recent times with regards to ICU and acute medicine provision. And finally, it's been very difficult, even when we have identified patients and investigated them, to provide them treatment in a safe way that both reassures them and their relatives. And so before I focus on a number of these different issues, I thought I'd put this slide up, which we have all seen numerous times. And the reason I put this up is really that unlike other pathologies where you can wait, you can postpone treatment and investigation, in aortic stenosis, with patients who present with symptoms that we think are attributable to the valve, we all know that the clock is ticking, that time is of the essence. And if we don't instigate an investigative pathway and treatment, patients do have bad outcomes. And so it's not about just keeping pathways open, but it's about keeping them slick and keeping them fast so that patients who have the most to gain do gain that benefit. So with regards to the patients themselves, as I've explained, these are vulnerable patients. They're often frail. They have multiple comorbidities. They're often in the elderly age group. And indeed, the public messaging is really focused upon this group. And so they have been told to stay at home, to save lives, including their own, and to protect the health service. Now, these are one and the same. And we therefore have an environment where lots of patients are really petrified of leaving their house, of seeking medical care, of calling their general practitioner or their cardiologist for help. And so many patients who are symptomatic sit at home and try and ignore their symptoms or think that their symptoms will go away because the risk of COVID far outweighs these. Now, the challenge here is that these patients are in fact the patients that have most to gain. They have in addition to symptoms and prognostic benefits of intervention, it's their best chance of maintaining independent living. They will, of course, have a reduction in hospitalizations. And of course, from a healthcare economy perspective, this is associated with a reduction in social care requirement and economic benefit. Now, this is the state of healthcare is probably true even before COVID, but we, of course, have an increasingly elderly population. We now have an even greater requirement for them to be more independent. And of course, we've talked about the symptoms and prognostic benefit. But with COVID, we've had postponement of routine appointments, and this is pertinent for patients who already have a diagnosis of aortic stenosis. They have had their routine surveillance scans or clinic appointments delayed. But with regards to de novo patients, often patients are being reviewed virtually over the phone or sometimes by video. So if a patient presents with breathlessness, for example, without a clinical examination or without a test, it's sometimes very difficult to determine if indeed it's aortic stenosis. So often valve disease may be missed. Similarly, diagnostic access has been challenging, access to echo or CT. So again, pathways can be delayed, diagnoses can be delayed, and sometimes outcomes can also be poorer than we otherwise would have hoped for. And finally, there's been a reduction in ancillary services, patient transport, for example. And so some of these elderly patients are struggling even to get in to sites to get their tests. And so we've talked about the challenges, but what can we do? Well, with regards to patients and the referrers, it's really important that we educate them. It is okay to ask for medical help. It's important to do that even with COVID. We can use smart technology to identify patients, for example, in our databases already for patients who already have diagnoses. But we can use video phoning, for example, to make initial assessments or of patients who are inpatients in referring centres. And indeed, the public messaging has now been changed to reflect these concerns. And finally, it's really important that we inform our referrers, primary care, community physicians, even our own hospital teams, for example, acute medicine or gerontology, that in fact, we are all working incredibly hard to keep these pathways open, because these patients really do have the most to gain and also the most to lose without treatment. And so it's really a public awareness issue as well. And then with regards to the patients, if we have identified these patients, well, it's important that we address their concerns. And this is around both reassuring them and also ensuring that we've minimized their risk. And so we can do this in a number of ways, and we can use virtual assessments as we've discussed. We have set up one-stop clinics to try and get a clinical assessment and all their tests done in one go. We can set up clean zones, COVID negative zones with patient and staff swabbing away from hot areas, and to try and minimize these visits to the shortest possible, again, to reassure patients and their families that we're minimizing their risk. Often these patients have been shielding for weeks and weeks and weeks, and this is the first time that we are actively asking them to leave their house. So, you know, this isn't a small undertaking when we are advising patients to do this. And the aim, of course, is to maintain and hopefully even improve clinical outcomes in this setting. Now, once we've identified patients and we've agreed that they are happy to come in for their one-stop clinic to be assessed, and we've determined they're suitable, we then finally have to counsel patients with regards to proceeding onto an intervention. And this I found personally has been one of the most challenging parts of managing these patients. It fundamentally becomes a balancing act. We've all become very good at discussing complications from the procedure. We've become very good at assessing CT and echo and technical considerations. But currently we now have the additional unknown of COVID. Do we wait? And we've all seen the poor outcomes of waiting with severe symptomatic aortic stenosis, or do we proceed now and accept a very small peri-procedural COVID risk? And so these challenges, these have been challenges in the patient conversation, and I've had numerous conversations with patients and families, and it's really very hard to quantify. We have no idea when the pandemic is going to pass. Is there going to be a second peak? We just have no idea. And so sometimes it just comes down to a personal choice in the end, in spite of all of our efforts. But I think that there are also some opportunities, and I know that these are just swift slides because they are the focus of the next two talks. But you know, I think that there have been pathway improvements as a consequence. I think we've been even more collaborative within the heart team. I think we've been better at rapid initial review. Patients are no longer waiting for the next available clinic appointment. We've been able to video, phone, or call patients much more quickly. We've been better at resource utilization, so patients come in once, get all their tests. We're maybe doing less of the superfluous tests, for example, carotid screening that we may have done previously. And I think for the patients that have been identified, in some instances, their pathways have been really very fast indeed. And finally, we can also modify procedures, and again, that's the focus of another talk, but again, we can minimize inpatient stay whilst maintaining outcomes. So in conclusion, COVID has really been challenging. It's been a challenging time for everyone, healthcare workers, patients, families, and it's really forced us to work in different ways. I think that as a medical profession, we've done well. We've worked with this. We've overcome some of these challenges, and we've adapted to both offer, identify, investigate, and counsel patients. And I think that some of these processes have in fact worked better than we did before, and I think they'll continue even after the pandemic. And so I finished this talk on a positive note to say that I think there may be some small positive effects of the current COVID pandemic. Thank you.
So Neil, that's fantastic. A very nice overview of the broader implications of the societal impact of COVID. David, I want to ask you, you have a very well-established network of nurse specialists who interact with your patients. Have they identified similar anxieties in the AS community that Neil has been describing?
I think Neil was absolutely on point. We did a great job shutting everything down. I think we've all learned now, and this is good to know if there is a second wave in the fall in the coming months, that we can turn everything off. But we did such a good job that patients were extremely reluctant to come into hospital. And we've had to do a tremendous amount of work reassuring patients and family that it is not only appropriate, but needed that they come in during this plateau phase to be appropriately treated for their severe symptomatic AS.
And Francesco, obviously in Italy, you've had more time to catch up. Have you seen a rebound phenomenon where lots of aortic stenosis is now coming in late, as it were, with congestive heart failure and very late symptoms?
Sure. We had, after the initial phase in which the patients were reluctant to present to the hospital, we had some patients that refused the treatment at the beginning of the outbreak, and then they started to call in asking for, accelerating. So yes, this is a problem that we saw, and that we should be more prepared should there be a second wave.
And of course, that presents further challenges to the service, which is trying to rebuild, as Neil has described. So, Francesco, please tell us about the scenario in Italy and how you've managed it thus far.
Thank you very much. My task is to describe how we restarted a smooth patient pathway during and after the outbreak, focusing in how we interacted with our referrers and community hospitals in order to prioritize patient access to treatment. Those are my conflicts of interest. Okay, as my colleagues pointed out, the COVID-19 pandemic posed a major challenge to the healthcare in general, and of course, pathways of cares for aortic stenosis patients were also severely affected. Challenges are described here, and we heard from the very nice presentation of Neil what they are, but just to recap a little bit, we needed to ensure appropriate and timely treatment to aortic stenosis patients. At the same time, we needed to minimize the risk of COVID-19 exposure to them and to their also for healthcare workers. And we needed to limit the resource utilization under those conditions of constraint. So how could we restart in this situation? How to face these challenges? We needed to create a COVID-free environment, and Neil told us how important was to restore safety and confidence of the patient in the hospital. We need to do an appropriate patient selection according to the epidemic phase to reprioritize patients. We needed to establish closer collaborations with referrers, and we needed to optimize aortic stenosis treatment programs. Okay, focus on patient selection according to the epidemic phase. We need to take into account two variables. Number one is the clinical status of the patient. We need to retriage patients based on their clinical status. I don't want to go into the details of these slides, but just to give the rationale, we need to identify those patients who need a treatment more soon than others, because we know that the situation of the patient can be changed from their initial evaluation. So we really need to retriage all the patients. And second variable is, of course, the epidemic stage. We have to take into account the situation in which our country, our region, our hospital are in. And of course, we had all a stage one in which there was the full outbreak, in which no regular services were possible. Then we had the stage immediately after the peak in which we were more prepared and we started to reorganize regular activity. And then we had a stage number 3, that is the stage in which there is the regression of the outbreak, in which there are minor restrictions in regular activity. So putting together those two variables, we had the reprioritization of TAVI planning of patients for TAVI. So in phase 1, so during the outbreak, we could allow only patients, only emergent or urgent procedures. Of course, in these situations, we had to work with the full personal protection equipment and develop specific pathways of treatment for the patients. Then in phase 2, you can start treat semi-urgent patients, and in this second situation, you of course need to have all the insurance for the patients and the healthcare workers, that the environment and the procedure can be done safely. And then in the phase 3, during the regression of the pandemic, the epidemic, you can restart some elective procedure, of course, cautiously. Okay, very important is during, especially at the beginning, but also in all those phases, to keep constant contact with the patients. So all the patients in the waiting list should be contacted, and this is what we did through an MD or the TAVI coordinator. All patients and family were given a telephone number to call during working hours, and we could have also from the hospital a formal and legal coverage of outpatients visit performed by telephone, so a kind of legal coverage of what we were doing. Of course, telemedicine offered us several opportunities, but I mean, we did most of this work by telephone call because we were not prepared. But this is comes into the opportunity that Neil suggested in his previous presentation. I think we could can use some of these features also for the future. And the concept, the rationale behind our, let's say, organization was that we must stay distant, physically distant from the patient, but they should feel close to us. They should feel they had a constant relationship with us should their clinical condition change in any direction. So, second thing that we had to set up was to maintain a dedicated outpatient. Of course, we try to limit as much as possible the access of the patient to the ambulatory, but we could not skip, in our opinion, this step for some patients because it's not always easy to understand clearly from the telephone call or from the distance how they are. But again, trying to create a clean environment. And number 3, establish close contact with referrers, maintain, I would say, and even enforce the contact with referrers. What we did is to establish weekly heart team with the referring centers. Of course, this was, let's say, the formal moment in which we could discuss new cases or changes of conditions of patients that were already in the waiting list. But as I say, this was the formal moment. But we also had, let's say, daily contact with them in case of need. So overall, just to say that this is not only theory. Maybe it was, as I said, we were surprised at the beginning, not well prepared. We did not employ immediately telemedicine. We used the telephone or let's say old-fashioned tools. But anyway, I think that the results were acceptable, were very good, because in this slide you can see that in the left, the situation in Italy. In Italy, we had a 69% reduction of TAVI during the outbreak. These are official data from the Italian Society of Interventional Cardiology. In the right side of the slide, you have the situation in Bologna. Adopting those measures, we were able, you see, in the first 5 months of the year to maintain the same number of TAVI procedures of the preceding years, the 2019, despite the full outbreak of COVID also in our region. We were the second most affected region in Italy.
So Francesco, congratulations to you and your team on maintaining the program so successfully in very difficult circumstances. We've moved very rapidly into a virtual world, and this brings its own difficulties with it. I rang a patient recently for a consultation, and they thought I was the man from the fish shop for the first 2 minutes of our discussion. So it certainly brings its difficulties. Neil, of course, we're dealing with elderly patients who maybe aren't familiar with digital technology. They may not have a mobile phone. They might not feel comfortable talking to the doctor. They might be hard of hearing. How do you overcome some of these challenges in the real world?
So we've done one of three things. We've tried to use videos, and we've tried to set it up so that we have families nearby to enable them to help with the technology. And we've been opportunistic. So when patients do come in for their echo or their CT, we try and make sure that one of us is there at the same time, so we can be opportunistic and see patients all in one go. But I think the virtual part is great for some of the assessment, but it doesn't completely replace the face-to-face assessment that we all do need.
And of course, we're missing out on echocardiography, which is essential for diagnosis, maybe not so much for observation and surveillance of patients, but certainly for diagnosis. David, I wanted to ask you about any trends that you may have seen from surgery towards TAVI. Are your surgeons recognizing the restrictions and the difficulties of open surgery at the moment and referring more patients for a transcatheter approach?
Absolutely, Bernard. That's a trend I think we're seeing not just in Europe, but throughout North America as well.
And could you give us a kind of a percentage transition that you've seen in the last 3 to 4 months?
I think it's going to be fascinating when we look back 12 to 18 months from now. For now, all I can say is anecdotally, when we reach out to all the different benchmark sites, clearly there was a trend in April and May of transitioning patients to minimally invasive procedures, both aortic and mitral.
And maybe ultimately that will be a positive win for patients as well. We need to remain optimistic.
Agree.
So moving forward now, we're going to come to the procedure itself, and our next speaker will be David, who's already done a lot of work developing refinement and simplification of TAVI pathways in Vancouver. And of course, you could say that that was work in preparation for a pandemic. So David, tell us about how you've refined it even further.
Great. Bernard, thank you so much. And obviously, Neil and Francesco, excellent talks. As you know, Bernard, I'm very much a glasses half full type of person. And I think the pandemic is a tremendous opportunity to revisit historical practices. So limiting the patient footprint in the hospital, this was a topic actually we had for TVT last week. And I think it absolutely resonates, not just in North America and Europe, but around the world. As Neil was saying, COVID-19 has impacted how we care for TAVI patients, both now and in the future. I think we all know that this is a dynamic situation over the next 12 to 18 months. We need to be able to ramp up and ramp down. Bernard, as you said, minimalist TAVI was optional. It was a nice thing to do, but took effort to put in all the policies and procedures to streamline your pre, peri, and post-procedural pathway. I would argue now it's essential. And this emerging concept, I'd like to get a little bit controversial, make this a little bit exciting for our audience, the idea of same-day discharge. I'll talk about a little bit of preliminary data that's already come out of the pandemic. So here we go. The last 12 weeks, if I would argue, have brought the interventional and structural community together in a way that I never would have even dreamed of in January or February of this year. We got together and shut down our respective countries. We did that in Canada in the bottom right. And then the most exciting thing, we got 15 different North American societies representing 90,000 clinicians to come together and come up with a safe reintroduction, not just for invasive cardiovascular procedures, but all of our diagnostic testing. And as you know, Bernard, they're intricately linked. So you can't just shut down your CT and echo and imaging and expect that your pipeline for TAVI is going to continue. And so this document, I think, will really help us as we look at what the penetrance of COVID is in the community until hopefully eventually we have a vaccine. We also wrote some interesting editorials just on streamlining the TAVI procedure further, which hopefully will be of use as we come out of the pandemic. So there's a tremendous opportunity to revisit historical practice. We want to be patient-centered. We've heard from Neil and then Francesco the rise of virtual medicine. And Francesco, I loved how you talked about distant but close. I'm going to use that now for some of the benchmark virtual activations. I think that's brilliant. The interdependence of imaging and invasive procedures has never been highlighted, especially in leadership positions where we're trying to restart everything in our centers. You can't just restart one piece. We've seen clearly, and there's a nice editorial coming out on CTA as the gatekeeper. Hopefully most of these patients have had an echo sometime in the past, but can we streamline it? So you just have a cardiac CT, of your virtual nursing assessment, of your virtual heart team meeting, and then the patient just comes in and has their procedure and goes home either the same day or the next day. Minimize the ICU footprint, absolutely crucial, and then same or next day discharge. So those are some of the things I'd love to highlight in the next 4 slides. So we did the 3M TAVR study. Obviously, we had fast TAVI in Europe. Both were the pillars that we built the benchmark program on. So we'd been doing the work prior to the pandemic, that 80% of patients could go home the next day safely. In Vancouver, our last 1,000 patients, all comers population, about 94% go home safely the next day with a 5% readmission rate. And we've seen, working with our colleagues, that streamlining the pre, the peri, and the post procedure at all these different sites have been instrumental to continue to care for our patients during the pandemic. This is the benchmark program. These are our wonderful sites, both in Europe and North America, using fast TAVI and 3M TAVR as the cornerstone. And we were able to achieve those benchmarks before the pandemic. And what I would say, Bernard, is it's even more important that we continue to achieve those benchmarks as we move through the pandemic and out of it. We are not going to sacrifice either efficacy or safety because of the pandemic. And we've clearly seen in the last 3 months, working with these sites around the world, that that is not the case. Francesco nicely highlighted that we've been able to keep up most of our run rates and continue to safely and effectively treat patients. And I think that is an exciting thing maybe we can chat about after the presentation here. And then finally, second to last slide, day case TAVI is not new. We've all had cases over the last several years, pre-existing pacemaker, who've gone home the same day, ideal aortic root and iliofemoral anatomy. But what is new is one of our benchmark sites in Middlesbrough got together their cases over the last 2 years. They used quite restrictive people who'd had a pre-existing device. They screened, I believe, 21. This will be coming out in JACC intervention. I can't show it yet. But of those, 14 met all of their criteria that you see them there listed, and 13 of 14 went home the same day with no 30-day readmissions and no complications. One patient was 87, they kept overnight and still went home the next day. So although intriguing, and for selected cases, it does speak to this whole idea of day case TAVI, which I think will be interesting as it evolves. Obviously, a lot of caveats. My colleague John Webb is always saying to me, "What's the rush, David?" But I think in select patients with ideal anatomy, whether they have a pacemaker or not, they're done early in the day. This might be something that we're seeing more and more of, and again, could be something that comes out as a plus on revisiting historical practice. And I've just put the same conclusions there as the opening, Bernard, but would love to chat with you and the others. Thank you.
So David, thank you for that fantastic description of your experiences in Vancouver. Before we come to our colleagues, I just want to ask you how you're handling the more complex patient subgroups. So the patients with nasty peripheral vascular disease, patients in whom you might want to do a transcaval procedure or some other more challenging anatomy. How are you managing that pathway?
I think that's a key point, Bernard, is this is all about communication with our hospital administration as well as our public health safety colleagues. I think they have an expertise, obviously, in the pandemic, but we understand our waiting lists and our patient population better than anyone in the world. So we've moved a whole group of patients to a very streamlined pathway done in a procedure room, a cath lab. We still do have those complex cases that we're doing in the hybrid OR, and that's an ongoing discussion with our administration about why those patients are appropriate and why they still need to be done as the pandemic waxes and wanes.
That's very clear. And turning to you, Francesco, I suspect that you have similar pathways to those described by David, but just tell us a little bit about the follow-up of the patients. Do they get a phone call at 1 week? Do they come back to an outpatient clinic? How are you managing them once they leave the hospital?
Well, to be really honest, I wish I was like David. We don't have the same organization, but yes, we participated to the Fast Tavi, and we tried to also to keep the hospital staying as short as possible. 1 day for me, for us, is not possible for many reasons. We try to keep it within 2-3 days. We have a 1 month visit for all, but for the most, let's say, patients in which we have some worries, we plan laboratory exams and a telephone call in a week. During the pandemic, we tried to limit as much as possible the visit, the follow-up visit, but of course, the telephone call was always performed.
And coming back to you, Neil, and thinking about the needs of patients and their families and their carers. Number one, early discharge might be a nice solution for the hospital, but it might evoke a lot of anxieties for the patient and their family. You know, they might worry about what's going to happen if they have a femoral bleed or something like that. So how do you manage the expectations, and how do you ensure that there is easy communication with the team if there is a problem?
Yeah, so I think it goes back to the counselling in the first place. So in addition to the procedural complications that we're all very well versed in, the discussion about COVID and reassurance. And so, in fact, I found that many patients are very keen to get home as quickly as possible, in fact. And previously they thought that we were trying to push them out of hospital because of economic costs, whereas now patients are really signing up to that. So I think a part of this is motivating families and patients that they may well go home that evening and they don't think they're going to be in for 3 days. And absolutely having a phone number that they can call, that we have our registrars or our fellows who man 24 hours a day, knowing that we are there for them to support them. And to mandate that phone call at a week just means that patients feel that they are not forgotten and haven't been discharged abruptly, but actually as part of the decision-making process. So I think thinking about it up front and really just ensuring that everyone's reading from the same hymn sheet means that everything normally works quite smoothly.
Yeah, and I think again the metaphor distant but close is a very nice way of describing it, isn't it? I also really like that expression, Francesco. Thank you. And we also need to recognise that our colleagues in primary care or family medicine are equally overwhelmed right now. And I think there is a responsibility for the TAVI service to really look after this cohort of patients internally, as it were, without leaning on other colleagues unnecessarily at a time when all branches of the medical profession are under duress. So, we've heard some fantastic presentations about the needs of patients, about the need to transition our services to a slicker virtual world, and the need to simplify our procedures to ensure absolute levels of safety for our patients, but also brisk discharge from the hospital to facilitate and simplify the pathway. So in conclusion, I think this seminar has demonstrated very adequately that valvular heart disease, and particularly severe aortic stenosis, is a critical condition in the current pandemic climate, and we need to remember the poor prognosis for these patients. Many patients who would normally be candidates for surgery do not have access to conventional surgical aortic valve replacement. And transcatheter techniques offer a particularly attractive treatment option for this cohort of patients at the present time. Not least because without treatment, they may well succumb to their valvular heart disease which has a higher predicted mortality than COVID itself. And as I hope we've demonstrated in this discussion and in this series of presentations, it is a time when the heart team really need to come together to discuss the needs of patients and consider the overall best strategy for their treatment, and to offer expedited, accelerated treatment in a simplified fashion for their overall benefit. So thank you to my colleagues for such wonderful presentations. Thank you to you all for joining us for this seminar session, and I hope you enjoy the rest of the virtual PCR offering.